So our next speaker is Dr Imran Aziz. Imran qualified in medicine honours from the University of Sheffield in 2004. He then undertook general medical and specialist gastroenterology training until 2016, whilst also completing a postgraduate degree on functional gastrointestinal disorders such as IBS. Following this, he undertook a 2-year postdoctoral fellowship in FGIDs at the Sahlgrenska Academy, University of Gothenburg, Sweden. He returned back to Sheffield in October 2018 as a senior clinical lecturer and honorary consultant gastroenterologist, and he's published original articles in high-impact journals. He's a co-author of the recently published BSG Guidelines on the Management of IBS, and he's been awarded the United European Gastroenterology Rising Star Award 2021, which is bestowed on promising young clinician scientists across Europe. So that's quite the remit there. He's going to talk to us today on the first RCT of low FODMAP versus gluten-free diet in IBS.
Thank you so much for the kind introduction. Welcome everybody, good morning. So this is a randomized controlled trial looking at dietary therapies in IBS. So to start with a bit of background, as you know, IBS is extremely common. It affects around 5 to 10% of the population, and the symptoms are characterized as chronic, frequent abdominal pain associated with an alteration in bowel habit. And these symptoms have got to be present in the absence of organic disease to explain their presence. Now, because food and the GI tract are intrinsically related, it comes as no surprise that many patients with IBS experience food-related symptoms. In fact, up to around 80%. And the most commonly implicated food agents are incompletely absorbed carbohydrates or fermentable carbohydrates such as dairy products, beans, fruit and vegetables, as well as wheat-based products. In addition, around 50% experience symptoms when they consume fried or fatty food. And there's a correlation between the severity of an individual's IBS and the number of food items that they are intolerant to. So the IBS patient is enthusiastic about their diet. And if you ask a generic open question to IBS patients, which could be any question, what would you like to know about IBS? The number one question is, what foods should I avoid? Around 63% ask that question. And if you ask another open generic question, which is, what have you tried for your IBS? Of the top 10 answers, all of them comprise some form of dietary modification. So food is high on the agenda for patients with IBS. And currently in mainstream gastroenterology, there are 3 main diets that are commonly popularized for the management of IBS. And that is traditional dietary advice, which is based on guidance from the British Dietetic Association. And that is considered to be first-line advice. Then, of course, you have the low FODMAP diet, which Christian has touched on, and this is then commonly accepted as a second-line dietary advice. And then finally, in the background, you also have the gluten-free diet, which is very popular, but currently is not recommended for the routine use in IBS. With regards to traditional dietary advice, this is based on adopting sensible, healthy eating patterns, such as reducing your intake of alcohol, caffeine, spicy meals, fatty food, increasing your fluid intake and adjusting your fiber. However, it's important to emphasize that these recommendations are not based on randomized controlled trials, but rather through anecdotal clinical experience and case control studies. With regards to low FODMAP diet, I won't touch on this in too much detail because I'm talking to a group of dietitians, but this involves reducing fermentable carbohydrates. And then finally, there's a gluten-free diet. And with regards to a gluten-free diet, this has almost become a global phenomenon. In all, around 10% of the population across the globe are reporting some symptoms related to consuming gluten-based products, yet of course only a fraction have celiac disease, around 1%. And what these individuals report is when they consume gluten-based products, these tends to trigger abdominal symptoms such as pain, bloating and altered bowel habit. Then the question arises, well, what exactly is it within gluten-based products that is triggering symptoms? This is a hotly debated area, and whilst in whilst there's some evidence to suggest gluten or non-gluten proteins such as wheat germ agglutinin and amylase trypsin inhibitors, the biggest or the key player seems to be fructans, which is commonly present within wheat-based products. So whilst dietary therapies are very popular for the management of IBS, I think it's important to realise that actually there's a lack of, the quality of evidence is suboptimal at this moment in time. So this was a recent systematic review and meta-analysis evaluating the efficacy of a gluten-free diet and a low FODMAP diet for the management of IBS. And here I'd like to highlight the conclusion, and that is that there's currently insufficient evidence to recommend a gluten-free diet, and that there is also very low quality evidence to recommend that a low FODMAP diet is effective in reducing symptoms of IBS. Now, when it comes to the gluten-free diet, the reason why it was deemed to have insufficient evidence is because this systematic review and meta-analysis recognized 2 robust randomized controlled trials, so there's not much out there. When it comes to a low FODMAP diet, there's more data out there. There's been around maybe up to about 10 randomized controlled trials. However, it's important to emphasize that a lot of these trials are small in sample size, but probably the biggest issue is that they have significant heterogeneity between the studies, and that is largely accounted for by the control group or the comparator group. So whilst on the one hand you have a low FODMAP diet, on the other hand the control group may be, for example, a high FODMAP diet, so you're exaggerating the effect. It may be a sham diet, which is the perfect study. It may be a traditional diet, or it could be habitual diet. So there's significant heterogeneity between the studies to draw any firm conclusion as to how effective the low FODMAP diet is. Not only that, the other main issue about a lot of these studies is that they are feeding control studies, and that's not real life. So here in these studies, patients are coming in, they're having their meals freshly prepared for them by the research facility. And that is not the same as when you provide dietary advice in clinical practice, because in clinical practice, the onus is then left on the patient to go and shop for the particular food, purchase it out of their own pocket, and then prepare the meal for themselves, but also their family members or friends. So it may have an impact on the cost and convenience to an individual. And finally, when it comes to dietary modifications, and particularly with restrictive diets like the gluten-free diet and a low FODMAP diet, we also have to be cautious that this can lead to significant alterations in the gut microbiome and reduce the diversity of the gut microbiome, such as reductions in bifidobacteria count, amongst others. And whilst we do not know the long-term implications of this change in dietary, change in the gut microbiome, it is worthy of further consideration and caution. So thus far, and in summary, I think I've highlighted that dietary therapies are very popular for the management of IBS, yet are being hampered by insufficient or low quality evidence. So this is where we decided to perform a randomized controlled trial and pragmatically assess the efficacy and the convenience of traditional dietary therapies, in IBS. And the 3 diets that we evaluated were traditional dietary advice, the low FODMAP diet, and the gluten-free diet. With regards to the gluten-free diet, this was not the strict gluten-free diet that you would give for a patient with celiac disease, because here we allowed some form of cross-contamination. So this is the study flowchart. So these were individuals with IBS according to the latest criteria, which is the Rome 4 definition. In total, we had 114 participants. They were block randomized into groups of 3 to 5 to receive one of the 3 different arms. Prior to undertaking the dietary therapies, they completed questionnaires on their symptoms, as well as providing a baseline stool sample. They then undertook the dietary therapy, and the questionnaires were repeated at week 4, as was the stool sample. Now, as I mentioned, this was a group-delivered therapy, and initially it was face-to-face. However, because of the COVID-19 pandemic kicking in, we had to change tact and change from face-to-face to online delivery of the online dietary education. So these are the endpoints. The primary endpoint was a 50-point reduction in the IBS symptom severity score. This is a validated tool, and a 50-point reduction is deemed to be clinically meaningful. The secondary endpoint was a greater magnitude of effect, i.e. 100 points. We also looked at the cost and convenience of the diet to the individual. changes in nutritional intake, and changes in the stool dysbiosis index. So these are the baseline clinical characteristics, which are very similar to what you'd expect for your IBS patients. So the vast majority were women, middle-aged, 89% were white race. In terms of the subtype, 75% were IBS diarrhea and 25% were IBS mixed. And also the vast majority were moderate to severe with regards to the severity of their IBS. So this is the main slide, which is looking at the clinical response based on the primary endpoint. So if you look at the bar graph on the left, in terms of a 50-point reduction, for traditional dietary advice, it was 46% had a 50-point reduction. For a low FODMAP diet, it was 55%, and then for a gluten-free diet, it was 58%. So across the three diets, there was no difference. There's a similar level of clinical efficacy. If we look for a higher magnitude of effect, which is a 100-point reduction, again, it's around a third across all three arms, so very similar. As I mentioned earlier, we had to change the mode of dietetic delivery, going from face-to-face as initially, which was for the first 30 participants, and then we swapped over to online following the COVID-19 pandemic. And what we found here, which was fortuitous in a way, that the symptom response was similar irrespective of whether you provide face-to-face group sessions compared to online group sessions. So for a 50-point reduction across all three arms, it was around 50% for face-to-face and online, and for a 100-point reduction, 40% versus 30%, so very similar. Moreover, we did not find a difference according to the subtype of IBS, whether it be IBS diarrhea or IBS mixed in terms of clinical response. This is another important slide which looks at the acceptability of dietary restriction. And I apologize if this is not very clear, but on the left-hand side are different questions that the individual asked about how acceptable the diet was for them. And the main points are highlighted within the boxes in red. So compared to traditional dietary advice, individuals found that the gluten-free diet and the low FODMAP diet took them extra time to shop and that it was more expensive. They also found that compared to a traditional diet, that the gluten-free and the low FODMAP diet was more difficult more difficult for them to follow when they were eating out with their friends and family. And finally, they found that the gluten-free and the low FODMAP diet were not as tasty and were not as easy to incorporate into their day-to-day life compared to traditional dietary advice. So the bottom line is that traditional dietary advice is cheap and cheerful compared to a gluten-free and a low FODMAP diet. This slide looks at the reduction in FODMAP intake across the three diets. So all three diets, there was a reduction in the FODMAP intake. However, the greatest degree of reduction was for the low FODMAP diet. So with the low FODMAP, which is in the middle column, at baseline, the intake was around 28 grams per day, and at week 4, or following the dietary therapy, it reduced to 7.6 grams per day. So it was a huge reduction across all the different FODMAPs. There was also a reduction in FODMAP intake using the gluten-free diet, but not to the same degree. So it went from 27 grams per day to 22 grams per day. And this was largely accounted for a reduction in fructans and galacto-oligosaccharides, which you would expect when you go on a gluten-free diet, as Christian alluded to in the previous talk. And finally, with the traditional diet, there was also a reduction in FODMAPs from 25 grams to around 15 grams. And this was accounted for by fructans, which I understand would have been due to reductions in fiber intake, and also lactose, which is something that patients are told to reduce if they perceive an intolerance as part of the traditional dietary advice. So what this highlights is that all three diets do lead to reduction in FODMAP intake, but it's a longer spectrum. And finally, we looked at changes in stool dysbiosis index to see if one diet was performing worse when it comes to gut microbiome changes compared to others, and we found no difference. So around a third across all three diets, had an improvement in their stool dysbiosis index, around a third had no change, and around a third had worsening stool dysbiosis index. So in conclusion, we've found that traditional dietary advice, the low FODMAP diet and the gluten-free diet all demonstrate similar levels of clinical efficacy. However, traditional dietary advice seems to be the most patient-friendly. We've also shown that dietary therapies can be delivered successfully online and via group sessions. From this data, we recommend that traditional dietary advice be used as a first-line dietary therapy, and that alternative, more restrictive diets, such as the low FODMAP and the gluten-free diet, may be considered as alternatives based on specific patient preference and in conjunction with the specialist dietetic input. And finally, I would like to thank all my co-authors, in particular Dr Anupam Raj, who's actually the first author and is writing this manuscript currently, but unfortunately could not be here today as he's presenting elsewhere. And I'd also like to thank Christian, Rachel and Nick, who have put together this meeting, but were also involved in this particular study, and of course Professor Sanders for co-supervising the study. Thank you so much for listening.
Thank you so much, Imran. That was a brilliant summary of the study. Do we have any questions at all from the floor? Yes, of course, Amanda.
Thank you so much, Imran, for being able to convert scientific findings into practical guidance for dietitians as a profession. Could I just ask you for a little bit more clarification about the gluten-free diet and how we should interpret what a gluten-free diet for the patient with IBS should look like? Oh. Is it free or is it reduced to a certain level?
Okay, so I might have to pass this on to Nick if I'm getting this completely wrong. From what I understand, it is a gluten-free, but not to the extent that you would require or expect from a celiac patient. So there was a degree of cross-contamination, there was a degree of relaxation. So all the same advice was given, but not the extra bits where you definitely had to make sure that, for example, you were using your own toaster, etc. Now, Nick, you may want to add on to that. I do apologise.
I can add to that. That was eloquently summarised, actually. So essentially, we were intentionally not applying the gluten-free diet in the study like we would do with patients with celiac disease, where you're worried about the risk of cross-contamination and resulting ongoing autoimmunity and potential for mucosal injury. So in patients with IBS, we very much apply it to the sense that they need to label read, but they're not worried about may contain products. They're not worried, just as Imran was summarising, cross-contamination in the kitchen or when they were eating out. So it is a gluten reduced or gluten-free diet in the sense that they're aware of labels, but it's not restrictive in the sense that it would be the same for someone with celiac disease. I hope that summarises it, but I'm happy to talk further about it if we get more questions online.
Marius?
Imran, thank you. Sometimes the simple studies are the most important. When you are asking the simple question and getting a simple answer is always very good. So there are 3 interventions, all of which showed some effectiveness, which is very similar.
So say that again, Marius.
There were 3 different dietary interventions, all of which showed similar results in terms of efficacy, shall we say. Do we think that that is a placebo effect?
It could well be, because the placebo effect for IBS is around 30 to 40%. So here we've seen a response around, I think it's about 48 to 55%. So there may be a slight effect, but it's not much greater than placebo. And in fact, that's always been the issue with IBS in general when it comes to even pharmacological trials. The effect over placebos at most been around 8 to 10%. So this is not particularly different to what you would expect from, let's say, a pharmacological trial. So there will be a placebo element to this as well, not undoubtedly.
So will it change management?
Not really, because I think this is one study, and I think whilst we may be able to make recommendations, I think it may well need other groups to do similar studies. But I would say that if I was a patient and I was given the option of 3 diets, which I was told that were all clinically very similar, but one was cheap and easy to incorporate into my social life, I know which one I would choose as first line.
Brilliant. We have got some more questions in the chat online, which I think may be important to address. Maybe we haven't quite got time now, but there was one about the swapping method through the study. I think we can maybe talk about, I think we would argue that was the strength of the study actually in demonstrating.
I think so. I think because of COVID, you can always get criticised when you do studies, but I think on this occasion, I think when the reviewers see this, what we did, it'd be a bit harsh to criticise us, to be honest, because this is the only option we have. We had to go from face-to-face to online, and it ended up being, and it could have gone wrong, but actually ended up being a bit of luck that we found that it was just as effective.
I think there's a few other questions maybe we can address. We can come back to them as well, but for now, thank you so much, Imran. That was really well summarised.
Thank you.